Good afternoon, everyone. My name is Avinesh Bhar. Just checking in to say hello and welcome. Thanks for joining us. We will give everyone here a couple of minutes before we go ahead and get started. But what I'm going to do is go ahead and kind of chat a little bit more, I guess, in the meantime. So let me go ahead and share my screen and get things going. This is going to be the fourth of our series of 5 separate tools of practice for sleep medicine. And this is the fourth one, which I'm excited about because it means that I get my life back again. I recently had a newborn addition to the family. So between this and managing colic and sleepless nights, it's been an interesting experience. So so the reason behind us setting this up is to reach out to people who are practitioners in their own field, and whether you're a nurse practitioner, whether you're a junior doctor or a doctor just wanting more understanding, is to make sure that we are actually somewhat familiar with CPAP because the growing recognition of how sleep apnea and its treatment is affecting all other comorbidities. We went through in previous webinars as well about the effect of sleep apnea from everything from blood pressure to cardiac to neurological disease, right up to blood sugar control, anxiety, mood disorders, and so on. So it's to allow practitioners to be somewhat familiar with it. Is not to train you to be specialists, but if you choose to, that's great. There's, I think, great building blocks here. We're going to put together all these 5 webinars and then release that as a fully fledged continuing education for credits, and it'll be a block, so much more, many hours put together. But please join us for the 5th one as well if you've already joined us before. And but if obviously we're here to help you answer any questions. So disclaimers, obviously, all rights reserved, blah blah blah. Feel free to share these videos. I'm not particular. I think education should be freely available. So feel free because you've registered, you will receive a video recording of this along with the information in terms of your, the post-test evaluation. And so feel free to share that with folks if you want to, but only those who register for this event will actually get the continuing education credits. About me. I'm a sleep doctor. I'm also pulmonary and critical care trained. I set up this virtual practice because I felt that a lot of what we do, the value we deliver, is not so much in person, but it's listening to patients and then putting that listening to what we know. And so that's why the reason behind all of this is to educate everyone around there, and so that when they recognize some of these issues with patients, they're able to treat them appropriately or refer them appropriately. Sleep is that virtual practice. It's integrated. We do everything from evaluation to testing and treatment. So we coordinate the whole spectrum of disease or evaluation so that at least patients know that this is their home for sleep and it's not a DME company and a sleep testing company. And how do we figure that out? It's been going really well. We've expanded pretty rapidly. And if you all have any questions, I'm obviously not busy enough to answer any sort of questions related to patient care, because I feel strongly enough that I think our patients deserve better. And so if you have any questions, any patients that you feel require additional help, please let us know. If I could ask everyone as well to make sure we mute on their end as well. So, all right. The continuing education credits, we're going to release within a few hours of this. So within 24 hours, you'll get the video along with the post-test evaluation. Go ahead and complete that. We give you a full week before next Wednesday, before we close the window to complete those evaluations. And we will release the certificates for those who pass a week after that. So within 2 weeks from today, you should receive your certificates. We hope a little sooner. So don't feel like we've forgotten you all. For those who did not pass, we will resend the test and also attach the video to it. So you do have a chance. Sometimes the questions, the way I've set it up, is not clear. So I don't want anyone to pay the price of that, especially if you put the effort of being here and trying to learn. The goal is not to fail. The goal is to learn. All right. So we'll go ahead and get started. We've covered previously OSA, or obstructive sleep apnea, evaluation and testing, meaning that when to recognize patients in different subtypes, in patients in cardiac history, renal history, psych history, neurological history, and so on, and trying to figure out which ones require evaluation. This part of it is once the patient's been tested and has a diagnosis, how do we go from there? The easy answer that you really can't fail most of the time is just saying it's CPAP, because CPAP is first line therapy, and it's first line for many reasons. And also trying to recommend appropriate OSA treatment, especially in patients that fail CPAP. So if you think about it, the algorithm is always going to hit CPAP first, unless the patient has not tolerated that. That being said, in patients who have not tolerated CPAP many years ago, this is no longer their father's CPAP, so to speak. The devices are way more advanced nowadays, way quieter, way more patient responsive, and the masks out there, the interfaces that we use, there are a large number of them. So you can't go wrong with CPAP. I think if you find the right practitioner and if you have a right DME partner, and everyone's on the same page to get patients acclimatized to it, I think patients should be fine. I think if just because someone had a bad experience many years ago does not mean they will definitely have a bad experience again. So I would encourage you all to retry PAP first. All right, so treatment options: positive airway pressure, dental appliances, surgical interventions, hypoglossal nerve stimulation, which is the Inspire device. That's the only current one in the market. Positional therapy, not a fan of that, but we'll talk about that. And weight loss, which I think should occur in conjunction with CPAP, and I'll explain why. Positive airway pressure, it's really a sophisticated or a fancy reverse vacuum cleaner. What it does is it pushes air in to keep your airway open. It doesn't actually help you breathe. Patients sometimes are like, well, I don't want to be dependent on a machine to breathe. It's like, well, the reason is it actually just keeps your airway open. It doesn't truly help you breathe. The patient has to breathe in and out on their own. The ventilation is their own. All the pressure that's applied is to try to keep the airway open so they don't have an obstruction. And it is cost effective. It is by far the easiest thing to get a patient on and acclimatized to before all the other therapies, which incur a whole lot higher costs and more complications. So generally, you really want to exhaust this option before you dive into anything else. PAP therapy works whether you have high, whether you're severe, whether you have AHI above 100, whether you have AHI just above 6. That being said, you know, most people say, well, if you're mild, then you should be able to tolerate all these other modalities. The difference is a lot of our mild right now is based on home sleep tests, which I explained in the previous webinar, will routinely underestimate severity. What we're finding in home sleep tests that then positions patients as mild, moderate, severe, in about 30 to 50% of these tests will grossly underestimate the severity of the disease. And plus, there's a lot of night-to-night variability as well. So that's why I think in terms of the foolproof or the safe proof is to kind of make sure that we apply CPAP first as a first option. CPAP is what we use or previously used was much more prevalent, which is where we apply a single pressure, meaning that when they come to the sleep lab, we titrate them to find out once they have a diagnosis to increase the pressure until we get rid of all the obstructive events. Generally, the most severe part of sleep apnea occurs in REM sleep and when you're supine. So previously we'd set like a CPAP of 13, CPAP of 11. However, what we find is that patients have various different sleep positions. They may drink alcohol on weekends. They may take an extra sleeping pill on another day. And all these things may have an impact. And so the continuous one set pressure seems to be falling out of favor because we have a lot more algorithms. The algorithms have really advanced in terms of how to meet the patient's needs and expectations, especially they're lying on their sides or even stomach sleepers, or whether they're on their backs all the time, whether they're on medications that suppress REM, for example, and they may have been offered during the sleep study. So the auto PAP is actually a much, much smarter device. It delivers constant pressure at that moment, but it then titrates up based on the resistance it experiences. So it's got its own sensors that decides on when to increase it. So within a minute or two of the obstruction increasing, meaning the resistance now when they're pushing in or when the machine's pushing in encounters resistance, it will go up in pressure. So whether you're in REM sleep, side sleep, back sleep, whether you're just about to fall asleep, it will titrate that up gradually. And generally, I will start most of my patients between 4 to 20 centimeters of water and let the machine do its magic. BIPAP therapy is a great therapy if the patients don't tolerate CPAP, or especially the auto CPAP. And I'm going to use the word CPAP routinely, but please, I'm normally referring to an auto CPAP and not just a straight CPAP. If the patients don't tolerate CPAP because the pressures requirements are high, for example, then BIPAP is better tolerated. A lot of patients right now are getting placed on automatic CPAP devices after a home sleep test, because home sleep tests are the preferred way for sleep apnea detection. So they will get placed on auto PAP devices. If they come back to you and they're complaining that they can't tolerate it, that's when you think of BiPAP. Sometimes if they've had the titration already in the sleep lab, they may actually progress to BiPAP use within the sleep lab itself. So then therapy will come back a recommendation to put the patient on BiPAP. The EPAP pressure or the lower pressure on the BiPAP is the exact same thing as a CPAP. It's to keep the airway open, so stent it open. Now, what sits on top of that is the IPAP, or inspiratory pressure, or inspiratory positive airway pressure. And that comes and goes based on the phase. So if you think of it this way, it's an up and down based on the phase of their breathing. Now, that EPAP always stays there. That's the pneumatic split or the airway stent. Now, then the IPAP is a driving pressure to deliver the pressure they need to actually inhale and so on. And then it goes back down to the EPAP again when they're in exhalation phase. It's used when our CPAP has failed. Patients tried it, they really didn't like it. The pressures were too high, they were not comfortable with it. And those patients, even though they got a home sleep study done and got diagnosed, then they should be sent to a sleep lab. A BiPAP also has the added advantage of going up to much higher EPAP pressure, so that pneumatic split can go up much higher, while in CPAP devices or auto CPAP, it goes up to 20. This one can go up to 25 or 30, depending on the manufacturer make. So in patients who are morbidly obese, these devices are much better tolerated. Some patients may have persistent hypoxia, which we tend to overlook, especially if you're doing a home sleep test and you put on the auto PAP device and you assume that that's being resolved. And I'll talk about this a little bit later. And also against when they're breathing out or difficulty exhaling against the CPAP pressure, that should also trigger maybe the consideration of a bilevel. But we'll talk about the other features within CPAP that you can utilize for that. And because of this pathway, a lot of patients are being diagnosed with sleep apnea. And if they start having trouble down the road, meaning within a few months, or if the symptoms are not resolving, so on, you should have a sense of saying, maybe we missed something on the home sleep test. This patient may require further treatment or testing via an in-lab titration. So you'll order a CPAP titration at that point, because they already have a diagnosis of sleep apnea. They don't need to go through a diagnostic portion of the sleep study in the lab, which takes 2 to 3 hours. They will just go in there and they will slap on the CPAP mask on them, and they will start increasing the pressure until the obstruction goes away, until the hypoxia goes away. And if the patient's pressures are too high, they may switch to BiPAP. Alternatively, if they see that the patient has other issues like periodic limb movement diseases and so on, or some other secondary sleep problem, that may also allow them to make or change your therapy. Like I mentioned, between the masks, whether you're using CPAP, auto CPAP, or you're using BiPAP, there's various interfaces. There are the nasal pillows that actually have little adjuncts that go in your nasal passages. Some people like that. The nasal interface is actually the most comfortable. We provide that generally to 90-95% of our patients. The reason being primarily that even if you're a mouth breather, the reason why you may be a mouth breather is because you can't breathe or you're not getting enough air through your nasal passages. Of course, there are some patients who are pure mouth breathers, and we should take note of that. But 90% of our patients get comfortable on the nasal for two reasons. One is it's a lot easier, it delivers air more effectively. Our nasal passages are built for that. Number two is that when you have a full face mask, even though it may seem more comfortable to the patient, what the pressure does is when you're forcing pressure down the nasal and oral passages, for the oral intake, it may actually force your tongue backwards. And when it pushes your tongue backwards, what it inadvertently does is that increases the pressure requirement of the machine to overcome the obstruction that the mask itself has created. So some patients with full face mask might actually need slightly higher pressures, and that's what's not tolerated versus a nasal mask. So I will routinely, even though someone says, well, I'm a mouth breather, if they're not tolerating their full face mask, I will switch them back to a nasal mask. But generally, most of my patients, 90%, I will start them off on a nasal mask. How do we improve adherence? Well, a lot of it is education, so we'll talk about that as well. I think it is incumbent upon us in our practice, because we manage the whole spectrum, and I'm not just turfing it off to a DME company to handle it. We normally will speak to the patient about why they referred to us, how the sleep apnea, potential sleep issues may be causing their medical problems. So you want to tie in what they're getting in terms of the evaluation and what the treatment may mean for their overall health. Even if they're not perceiving any sleepiness and so on, and they were forced by their partner because they're snoring, the goal is here is to actually tie in all their medical problems, their symptoms, and to what PAP therapy could potentially do for them. Now, obviously, they don't find that it's going to, they're not sleepy or I'm not tired, I'm just forced here by my spouse. You have to educate them about that. Risk perception as well. Oh, I'm fine, I'm doing okay, my blood pressure is good. Yes, your blood pressure may be good for now, but you're on already 2 blood pressure medications and so on. So that's also a concern. It's like, oh, my blood pressure is fine. Yes, it is fine. You're on multiple medications to keep it at that level. So we want to talk about if we get treatment done appropriately, they might actually come off some of their medications or lower the dose. Nasal obstruction is something I routinely will review. However, a lot of patients do feel better after using the humidified air. So like I mentioned, you need to educate them on why they're there, why you need, and if you do it as a primary care doctor or not a primary care provider, it is great because when they start getting the sleep tests and then the CPAP won't be a surprise to them. It's already expected. This is why we're evaluating you. We also try to work with reducing nasal obstruction using saltwater rinses, using Flonase or any sort of nasal corticosteroid. Social support from their family members, especially in the elderly, is really helpful. Hypnotics are not a bad idea for short-term use. A lot of these patients, especially women, tend to already complain of insomnia, so a lot of them will come to me on Ambien and Trazodone. I don't try to take that away immediately because I find that the adjustment to CPAP is already something that's nerve-wracking for them. And now here is this doctor that I just barely know is asking me to stop my sleep medications. I use the sleep medications already prescribed to the advantage of allowing them to actually fall asleep and be drowsy enough. A lot of patients will say, oh, the pressure is too high. It's because when they put it on, they're not even sleepy yet. They put it on because they're trying to be ready for the night and so on, but the anxiety of it actually increases their perception of where the pressure is or how high the pressure is. So yeah, short course of hypnotics is not bad. And we'll talk about the troubleshooting tip as well. Oral appliance therapy. This is great, especially in patients who don't tolerate CPAP. It is a custom-made device, a mandible device that actually sits on the upper jaw and the lower jaw. So it has to be custom-made. Usually you want to, or not usually, you should go to a sleep certified dentist. And when you are evaluating a dentist for that, just make sure that they have adequate sleep training. What they want to do is actually ensure that they keep the lower jaw in place. So when your lower jaw is in place right here, it brings your tongue forward. So your tongue doesn't act as an obstruction. So all they do is actually keep the lower jaw as close as possible to the upper jaw. They have to be evaluated by a sleep certified dentist because the sleep certified dentist has to see if the patient may actually respond to it. Sometimes the dentition is poor. Sometimes the jaw is already naturally so far forward that they don't think they can improve it enough, and that won't be the right therapy. So an evaluation, especially in some patients who are struggling with CPAP and you've tried and DME has tried and they've tried different masks, is to evaluate them. But it's usually covered by insurances, especially if they've already failed CPAP. It usually is great for mild to moderate sleep apnea. You have to have good dentition. It may cause TMJ pain. So that's why how it's adjusted is over a period of weeks to months. The dentist itself will adjust the lower jaw forward by about less than 1 millimeter each time to avoid TMJ problems. And it's slowly, instead of yanking the lower jaw forward, it's slowly titrating the lower jaw forward, especially during sleep when they have it on. Now,
good dentist.
Yes, you want to go to a good dentist. If you don't mind just muting yourself. Yes, and so definitely you want to go to a good dentist, someone that's well-trained that will know as well that they need to have a sleep study after that to verify that the sleep apnea is resolved. We find that in patients now, we don't want perfect to be the enemy of good. I find a lot of patients who are struggling with it and so on, and you're saying, well, theirs might be severe, but if they're not using their CPAP and they've already tried everything, then why stick with CPAP and have the patient frustrated? So you have to have a plan B. In some patients who tried, if they're able to use their mandible advancement device, even though it doesn't get the AHI down as well as CPAP, you want to make sure you go for as good a therapy as you can, not necessarily wait for the perfect therapy in terms of CPAP and leave the patient frustrated and then lose trust in you as well. These devices are expensive, so the out-of-pocket cost is higher. So that's why you want them evaluated by a good dentist that can tell them what the cost is going to be like, so the patient can make an educated decision on whether they want to go forward with that. I have a lot of patients, for example, who travel a lot. So they want to use their PAP device at home. And if they're business travelers, or if they go camping, or if they, in airplanes and they travel so much, they don't want to carry the device or the CPAP along, even though the CPAP devices are way more comfortable and easier to carry around nowadays. That's a great time as well to use the oral appliance therapy. So like I say, over weeks to months, and they need to have a sleep study after that to verify that the device is actually working the way it should, because you want to get the AHI down. Sometimes you can't. And then you may want to think actually combining the oral appliance and the CPAP. What that does is it allows the CPAP pressures to be a little bit lower. And if they were not tolerating the high pressures, that's a great adjunct to use with CPAP as well, which we'll talk about later. Surgical options. My first disclaimer, I'm not a big fan of this. The reason is I find that, or we found that and I say we, I mean people who've done actual research, I just read the research. When patients undergo a lot of surgical changes or they go for surgical treatment, these patients already have a likelihood of an obstruction occurring. And we now know, at least in sleep medicine, that the one fell swoop of, oh, let me just remove your tonsils, or let me just do this, it's going to fix your snoring. It might stop your snoring for a while, but what the snoring and the tells me is that you have a airway or a narrowing of your airway that is developing, and it may continue to develop. So even though I get rid of your tonsils, or even though they do the UPPP, which is where they remove the soft palate and they also remove the uvula and so on, there's a chance that even though the airway may look bigger, but we don't know about lateral collapse of the airway and anterior posterior, which is where the tongue goes backwards as well. So we're finding a lot of the patients that undergo surgery many years later, or not so many years later, have recurrence of the symptoms. So the surgery hasn't been as effective as possible. Now, what about future weight gain? Can you guarantee the patient's not going to gain weight? No. So at this point, you want to think of surgical options as a last gap measure as well. And don't forget, after the surgery, you need to have a sleep study to verify that it's resolved. You should get one before and after, because if you have sleep apnea, they need to reconsider whether they're doing the surgery for snoring or sleep apnea. The options, you can remove your tonsils and adenoids, which work much better in children. But even in children now, we're finding that the improvement related to surgical options is not long lasting. The UPPP has fallen out of favor. The RFA, or the radiofrequency ablation, along with laser-assisted uvulopalataloplasty, I just call it LAUP, is not long lasting and against most recommendations now. Tracheostomies work really well because it's all it does is go overcome the obstruction here, but that's reserved for patients who are with morbid obesity or BMIs above 50 and 60. And because the pressure requirements are so high on the CPAP or BIPAP, they can't tolerate it. And because of them not being on CPAP, they're suffering from frequent cardiac issues, frequent respiratory failures. Those patients are definitely the ones that you want to switch over to tracheostomies. But generally, surgical options should be considered as a last gap measure. The ones that are really good is the MMA, or the maxillomandibular where they actually surgically move your jaw forward. A lot of these patients have recessed jaws or smaller jaws, and so they actually reconstruct the jaw forward, so that pulls the tongue forward as well. And these patients are in a similar mold of patients who are suffering the effects, cardiac effects, whether it's arrhythmias, whether it's heart failure, whether it's frequent events that lead them to the hospital, very severe patients. And these tracheostomy and the MMA should be considered in these patients. We do use tonsillectomy sometimes to our favor when the pressure settings are too high on the patient and they have class 3 tonsils or near kissing, or kissing tonsils or near kissing tonsils. Those patients, if they can't tolerate the high pressures, it's a great way to open up the airway so they can tolerate the pressure, but it probably means they still need the CPAP. Inspired devices. It's been a great addition to the market. I think it allows patients who can't tolerate CPAP. Again, the caveat is that you have to work with a provider or in a DME company that really has tried to work with the patient to make sure they have the best chance possible. The next line would usually be a mandible advancement device if they can't tolerate that. Some people go straight to the Inspire device. My concern or caution with the Inspire device is you have to send it to a dentist who's definitely qualified, and those who apply the Inspire device are qualified through the Inspire company. They will do a sleep endoscopy to assess the collapsibility of the airway. Because just because you don't tolerate CPAP and you don't want the manual advancement device doesn't mean you're going to benefit from the device. So the ENT surgeon will actually induce a state of sleep with sedatives, and they will actually go in through the back of your nose, through your nose, nasal passages with the video scope, and they will look and see whether there's anterior posterior collapse. So the whole idea of this is to actually trigger or pick up when there's a trigger in the breath, and then it will release a stimulation here to the hypoglossal nerve to actually tighten up your tongue. So your tongue, instead of flopping backwards, stays forward. So some patients actually end up sticking their tongue out at night over and over again because they get stimulated. But you actually have to switch on the device right before you go to sleep and switch it off when you wake up. But this device works really well. Only thing, like I said, it depends on making sure that they don't have collapsibility in the lateral portion. It might work for the anterior posterior collapse when it's trying to keep your tongue forward. But if you have lateral collapse, and that's what we're finding in some patients, even though they initially got evaluated, they were good Inspire candidates, we're finding a lot of these patients will fail it down the road because they eventually develop a lateral collapse due to weight gain, due to changes in their body habitus, and so on. Like I say, it delivers an electrical pulse to keep the tone of the tongue and the airway patent, and they actually have to switch it on and switch it off. So patients need to be comfortable with that. The recommendations should alert you to the fact that it cannot be or should not be for every patient. Look at the BMI. The BMI here is going to be less than 32 because as you increase your weight, your chances of lateral collapse increases as well. And that will fail this device. So even though you've had this place, and can you imagine someone with an AICD here and this device here, it scares me that patients have all these devices and one of them, if it's not working because the patient's gained weight, is going to be a concern. So definitely you have to pick the right patient, and the surgeon has to be working well with the patient to kind of give them an idea of what may happen in the future. You can use it for moderate to severe sleep apnea as well. Not recommended if you have anatomical findings, and I've highlighted that here because if you have lateral collapse, you should be very concerned about doing it. If patients may need MRIs, they've had a long neurological history, to think about that as well. I'm sure at some point they'll come up with an MRI compatible version of it, or it may already have come out, but yeah, look into that. If they have other incompatible devices as well. If they have central apneas, then you will not find an improvement because central apneas are not triggered by respiratory effort. You actually have no respiratory effort. So the Inspire device is not going to work for central apneas, it's mainly going to work for obstructive apneas. Positional therapy. Now, it may work if, for example, a lot of home sleep studies don't actually give you position. Some of them do. And so you can tell, oh, it's mild, but it only increased to moderate when they're sleeping on their back. So, hey, can I get the patient to sleep on their sides? It sounds like a great idea. However, we cannot control which position the patient sleeps in. Even though when the patients swear that they only sleep in one certain position, they're not aware of it. And so sometimes you have to take that with a grain of salt. Now they have pains and aches and so on. They can't do positional therapy. There's a lot of these new devices up now where you can wear a vest that has something on their back that irritates them, makes them uncomfortable when they're laying on their back, so they'll turn over. And you find online as well things that you can do as a home remedy. But again, the same way that the analogy would be the same way that the surgeon has to evaluate someone beforehand to see whether, okay, if I can get rid of the adenoids or if I can do a certain the UPPP surgery, but am I going to find that this patient actually has collapsibility in different areas? And are they going to slowly progress to that? So in someone that I have or I recommend positional therapy to, which is very rare, it always is with the caveat saying that if you have issues or you have these symptoms recur, come back to me, because it just means that your positional therapy now is not working. Weight loss. Great tool, but not realistic in the short term. Once someone has sleep apnea or OSA, the body's sort of milieu changes. Patients are higher in stress levels, stress hormones. There's other hormones that actually, because of sleep apnea or poor sleep, actually causes weight loss to occur much slower or doesn't even allow it at all, because you tend to not stick to a diet, you're tired, you're exhausted, you can't even motivate yourself to move a lot. I will actually a lot of times tell patients, weight loss is your moderate or medium to long-term goal. We need to stabilize this ship right now. We need to put you on CPAP so you can actually get good sleep. You can actually feel more refreshed in the morning. You feel like you got great sleep. Your energy levels are higher during the day. Your hormones in your body as well actually allow you to stick to a diet plan, and you're not grazing or you're not trying to calorie load because of the effect of poor sleep on your body. Now, it can be curative, and we deal with a lot of bariatric patients, so we end up getting them on CPAP, so they go through surgery safely. But as they lose weight, you can actually see the pressure requirements, and we'll talk about this, how you can look into a modem and see what pressure settings they're on. And once you have those pressure settings, you can actually see through the modem what the pressure requirements are. So you have an auto PAP machine, 4 to 20, and you start seeing when they started off, they get their 90th percentile, or where the pressure is most is like 12 or 13. As they start losing weight, you can start seeing the pressure requirements go down and come down to near normal level. At that point, you can maybe stop the CPAP. So those are things I think are really valuable in patients, but to educate them that really, as much as weight loss, if you're just snoring and you're overweight, that's different. If you have sleep apnea, it is going to be a lot harder. You may want to try a short course of weight loss and then bring the patient back in and say, okay, how is it going? We need to move with CPAP if they're resistant initially. What about oxygen? I think oxygen is great. It is not a single standalone tool. Sometimes it also worsens the outcome because the body doesn't get a trigger to breathe if the oxygen levels are fine, but the CO2 levels may keep increasing, or it may prolong their apneas as well because there's no alarm bell going, your oxygen levels are lower. But we do find it works really good in adjunct to patients who are on BIPAP, who still are hypoxic. And that's when you may want to go up on that IPAP setting to improve ventilation, which also helps, and also increase the EPAP if there's an issue with obstruction. So oxygen in conjunction with PAP is great. In some patients, for example, we'll talk about this a little bit later, if you have persistent symptoms despite being on auto PAP and you think your compliance is good and everything else looks great, is to send them to the sleep lab and see whether hypoxia is still an issue. Because just because the hypoxia was there with the obstructive events during the home sleep study, it may still persist to a certain degree, depending on how severe the disease is. Stimulants is another one, which we'll talk about as well. All right, so we've talked about the various treatment recommendations with the CPAP, surgical therapy, oral appliance therapy, weight loss, positional therapy. We've looked at all of that, or even the Inspire device as well. And you can recommend, but the first line is always going to be CPAP in patients. And then if they fail that, to kind of escalate care depending on what the needs are. Again, how hard or how much you push depends on the comorbidities the patient's facing, and also along with the symptoms that they have. So now let's shift gears and say, how do we manage these patients once they're on these treatments? So we'll talk about follow-up care and how to follow up these patients. And again, troubleshooting with PAP, because that's going to be the mainstay of therapy for most patients. You want to make sure that when you're following up on them, if you're just a sleep doctor, following up patients, I generally will follow up patients once a year. If they're on autopilot, they're on an auto PAP device, they have no complaints with the pressure, their settings are great, they're finding it good, they're comfortable, they're getting the benefits from it. Their usage is 7 hours, 6.5, 7 hours at the minimum. They're doing well on it, no problems. I normally will let them loose and let them come back once a year just to check back in again. But it also is, your long-term is to kind of make sure that they're using any, before you do that, is to make sure that they're using it well. You want to also guide the patients to say, okay, now you're using it well, and you start seeing the long-term improvements, meaning that if you had issues with anxiety, if you have issues with depression, if you had issues with blood pressure or atrial fibrillation, you want to start seeing improvements overall now that you're complying with it. And you may want to prod and poke your provider who's giving you these medications, asking them, do I need to be on these medications longer now that I feel much better, or my cardiac issues are better addressed, and so on, or blood pressure issues? Now, how do you assess patients? It always depends on what their baseline symptoms are, because everyone's going to have a checklist of different symptoms. You want to make sure you always follow up on that, because patients want to know whether they're improving. They may not tell you firsthand, like, if you ask them how they're feeling, well, I'm feeling fine, I'm feeling better. What do you mean by better? And so if you look at your previous note, if patient was snoring, or they're waking up multiple times, nocturia, waking up with headaches, waking up feeling unrefreshed, taking naps during the day, or symptoms such as that, or they have cardiac issues, or they have blood pressure issues, or they kept waking up in the middle of the night having panic attacks. Bad dreams is another one as well. The patients have this sensation that they're choking, which they really are. Difficulty falling asleep. Sometimes as you're having an apneic episode, as you're falling asleep and your airway is collapsing, what tends to happen is that you then wake up in a hypnic jerk. So you kind of jerk awake. And so what the CPAP does is actually keep that airway open. So as you're drifting off as well, you can drift off. So you want to ask about the ability to fall asleep as well. If they have any issues, pressure too high, too low, the mask, humidifier, we'll go through this all in a little bit as well. You want to make sure you address all these issues to optimize their use on CPAP. If they have dental appliances, find out if they have any TMJ problem, loose teeth, bite issues, refer them back to the dentist sooner if they have those issues. Positional therapy, if it's not working, the sleep issues have recurred, or they have pain issues, that's when you want to reconsider that. Inspire therapy, device issues, whether it's a pain issue, whether it's a kinking or not kinking, but in terms of the leads and so on, if there's any issues related to that, they have to be titrated as well for the inspired devices. Usually it's either the ENT surgeon or the sleep doctor who referred them will manage that and make sure that the device is titrated, because the amount of shock or the electrical stimulation delivered to the tongue will differ based on how they respond to lower levels, and they will keep increasing it to make sure that that's not an issue. And they always test that out against a sleep study. Usually if you had a home sleep test to get you qualified, then you should have a home sleep test after that. It's kind of like to like compatibility or comparison, or if they have a PSG or in-lab study, then make sure that after that is also PSG. Now you want to get the PAP report. Now PAP reports used to make my eyes glaze over because there's a whole bunch of information there. But what I'm going to do is show you some things that you just really need to look at. So you can look, it can either be a download. Now there's a lot of modems, these patients, CPAPs are built in with a modem that transmits it to the cloud. So we immediately get it and are able to upload it to the patient's chart. But if they're not, then usually the DME company will fax you over some of their requirement, or at least the download information. Some machines still have the data card. If their modem isn't working and so on, that's a way for the DME company to send over a data card and have them mail back the SD card so that they can upload it to the cloud. So we'll kind of go through that in a little bit. You want to make sure the percentage of use is above 70%, and that's mainly an insurance requirement. I always strive for making sure they're using it for the duration of their sleep. So the goal is to treat sleep apnea while you're asleep, not for 4 hours. 4 hours is an insurance requirement. And that's why it sometimes upsets me that DME companies go just 4 hours, and patients actually literally, after 4 hours of use, take the mask off and put it aside. And you don't want them to do that. You want to see what the usage patterns are. Let's say weekends they're skipping it, or certain weekdays they're off, and try to figure out what's going on with them. But generally you want to see usage above 70%, and those 70% usage has to be above the 4 hours. And you'll see it over here. Usage days above 4 hours, 87%. Now this is a grade 1 patients at 30 over 30 usage days. 4 days, they use it for less. But this is another one, apart from the 4 hours usage here, that is important, is to see on days used, average usage on days used. Now, total days will also include days that they had maybe trouble with, or they didn't use it, and so on. So that averages out, kind of gives you a slightly lower. In this case, the patients use it for 5 hours and 47 minutes on the days they've actually used it. That's the average on days used, as opposed to all days used or not used. And so that 5 hours and 45 minutes, if the patient comes back to me still complaining of sleepiness or sluggishness or so on, I'm going to get them to push that as much as possible, as close to 7 to 7.5 hours if possible, because that just tells me that they still may be underutilizing their CPAP. Obviously, if patients have just scheduling issues because of kids, family members, sickly family members, just they have to wake up really early for work and they can't go to sleep until a certain time when their kids are asleep, that's obviously something to consider as well. Insurer requirements, you have to be seen after 30 to 90, between 30 and 90 days to document usage. And you want to make sure that they're using it well for above the 70% of the time. So after a month, I generally will see patients as soon as I see them and I prescribe therapy, I'll see them within about 8 to 10 weeks. That allows time for the machine to go out, for the patient to get acclimatized the first 2 to 3 weeks. And I normally warn a patient that the first 2 to 3 weeks are the hardest time to get acclimatized to it, because it does take time to get used to the idea. Older patients take a little bit longer. So you want to give them the warning of that, but you want to give them the expectation that everyone goes through that. You're not the only one. And it does take persistent use. So even if you don't use it well, the first 3-4 nights, you're using it for 45 minutes, an hour and a half. Continue using it and you will get better and better adjusted to it. But you also want feedback from the patient, what's stopping them from using it more often. The PAP therapy report as well, you want to look at, apart from the usage, you want to see the AHI. The AHI is actually a number that's generated from the system itself. So if you have patients who still have symptoms, are not feeling great and still feeling tired, or still waking up multiple times at night, or still have the persistent sleep issues that they came in with and some of them haven't resolved, you shouldn't just be happy, oh, you feel more refreshed? Yeah, I feel more refreshed. Are you still going to the restroom? Are you waking up with headache? Do you feel great in the thing? Do you still take naps? Because the reason is you really need to figure out whether the symptoms improve, because the AHI may be misleading. Even though the AHI may look normal on the PAP therapy reports, if your patient still has symptoms, I urge you to send them to the sleep lab to get a titration study to make sure that is correct, because they may need a BIPAP. They may have a secondary sleep issue that's going on. So not rely on just the output from the report itself, because then you're relying on a black box algorithm that you hope is working right for you. So just in case if your patients still have persistent symptoms, just note that you should send them, even though the AHI is normal, to send them to the sleep lab. Pressure settings. Check if the machine is set correctly. If you ordered 4 to 20, it should set 4 to 20 on the machine itself, and I'll show you that in a little bit. And you want to check what the 90th or 95th percentile pressure is. So mainly within which range or up to what pressure is the patient mainly remaining. If, for example, you see the 95th or the 90th percentile close to, let's say in this case, the example here is 5 to 15. If you see it in the 13.9 or 14.2 range as the 90th percentile, you may want to increase it. That's why I generally will not, I will just put adjustment of 4 to 20 in these patients and see how the patient does, unless they complain of, oh my God, I'm waking up because I'm feeling overwhelmed with too much pressure. At that point, you may want to check the 90th percentile, bring down that level a little bit more, but we'll talk about that soon. This is where you look. The minimum set pressure is 5, max 20. The humidity is what the patient can change on their own. You want to check the 90th percentile. In this case, it's 7, so it's great. I would still leave this 20 up here. I just don't want to tweak and change things too much because there's more work on my end. And if the patient's not complaining or waking up with too high pressures, I leave it as is. It's only in situations like this when it's set to 5 to 15 and you have a 90th percentile that's 12 to 13 already, and the patient's like, well, sometimes I feel like I'm not getting like enough pressure, you may want to increase that. This one over here is what the BIPAP setting should look like. There's an IPAP and the EPAP pressure here, just kind of give you an idea of what that looks like on a PAP therapy report. So these are 3 separate reports. It's not all the same report, by the way. You want to always assess symptoms. Are they still snoring? If they're still snoring, they shouldn't be snoring. That was the first reason they were sent by their spouse or the bed partner. So check the mask fit. As masks get older, you also have an issue where masks will start slipping and sliding and get out of place a little bit longer, more, and cause the snoring to occur or the leak to occur. So in patients with facial hair as well, these masks will slip and slide more. So as I give them the analogy, as your mask ages, you want to make sure that you're keeping it clean more often. You can get away with not cleaning it for more than, every 5 to 7 days when it's brand new, because the integrity of the mask and the rubber is great and it sticks there and it doesn't move around much. As your facial oils also start adding to it and the mask integrity gets softer because it's more malleable now, and even the headgears and so on, the stretch starts loosening, you might find your mask slip and slide. So if they're still snoring or they're waking up complaining of leaks and so on, like it's shooting up into the eyes and so on, that's when you want to consider whether you need to check their mask, making sure that they're keeping their mask clean. If they're facial hair, I know some men are very much tied to their facial hair, so I don't think it's something you may want to suggest, but maybe just shave it down a little bit if possible. Morning headaches, if they have morning headaches or and despite having good adherence, they're still symptomatic, consider checking an overnight pulse oximetry. I generally will jump straight to the in-lab titration, because if they're not feeling great and they still have symptoms and I've done a home sleep study, I will go ahead and get the in-lab titration done, because I may have missed out on a secondary sleep issue, but I also may have missed out on hypoxia as well, which the in-lab titration is kind of a one fell swoop, and you can go ahead and get them treated and change management based on that. If your overnight pulse oximetry comes back negative, for example, you're still gonna, or that doesn't show any desaturations, you're still gonna go ahead and get an in-lab titration. And this is regardless of whether the AHI on the device, on the therapy report, is normal or abnormal. I will say that again, please make sure that regardless of that, if your symptoms, the patient has symptoms and your AHI shows normal on the PAP therapy report, disregard the PAP therapy report, send them in for a titration study to see if there's any secondary issues or if persistent hypoxia is going on. Daytime sleepiness is another one. Always look at we want to make sure that the first thing that triggers, I want you all to make sure that the first thing that triggers is look at the amount of time on the days used, the average on days used. If it's still showing 5.5 hours or 4.5 hours or 6 hours, So keep encouraging the patient to use it because they feel like, wow, I started off at 2 hours and now I'm 6 hours. I've knocked it out of the park. But in terms of good quality sleep, we know what the recommendations are for adults. So you want to get it up as close. So keep encouraging them to use it longer and longer if they have the time to do that. The next thing you want to look at is see this is secondary cause or secondary sleep disorder. In that case, you want to send them to the sleep lab, but that's after you've adjusted the time, making sure the leak is not an issue, the mask fit is great, the humidifier is fine. You go through all those troubleshooting steps, and then you start looking for, okay, do I need, because sending them to sleep lab is also troublesome. It also is longer because they have to schedule that. And now with COVID or this post-COVID era, people are not being packed in and so on. The sleep labs, they're not really being packed in. I mean, you have a room separate and so on. It might be harder to get patients in because of how they've kind of changed some of their workflow. Assess other sleepiness factors as well. Medications is the biggest thing. One of the biggest things. Always look at the medication list. If the medication list is something like, if they were suffering anxiety before, insomnia before, and they were on trazodone before, and they're still feeling sleepy, look at the medication and see whether you can start or encourage the provider to start cutting that down as well. That'll be extremely helpful. All right, but then obviously other medical conditions as well need to be considered. Some patients will remain symptomatic for sleepiness despite whatever you do. So that's why we always have to do whatever we can until we get to that point. If we jump straight to stimulants, a lot more patients will be on stimulants than needed to be, and they will suffer the effects of just having stimulants in their lives. So you want to make sure that you've tried troubleshooting all these other issues, and if you need it, then go ahead and get the stimulant on board. But I would suggest that the patient get a CPAP titration before you jump to starting stimulants, because there may be a secondary issue that you're ignoring right now. And again, stimulants are also a scheduled drug, and so you'll have to prescribe it every month, and you have to be on a wet signature and so on. So you want to make sure that a lot of these stimulants are also really indicated, because it's going to cost you more time, but it's also going to cost the patient a lot more in terms of side effects and potential issues. Now, we talked about briefly overlooked or looked over the PAP troubleshooting tips, but these are the issues that we'll dive into a little bit: pressure, mask issues, nasal or mouth dryness, nasal congestion, anxiety, and claustrophobia. So high pressures, why do they occur? They don't occur as much now because we're using the auto titrating machine, but at times as the machine pressure goes up and down, sometimes they may wake up when it's at its higher or even highest level. And that alarms patients because they say, whoa, I fell asleep at 4 and now it's up at 11 and I'm waking up and the pressure's high. It may not be the high pressure itself. We have a tendency to have an arousal once or twice a night on average, and then able to fall back asleep again. It may be a normal arousal. So you're going to find out if the patient is able to fall back asleep again. What they can also do is just hit the ramp button. All these devices have a ramp button that's easily accessible. What that does is it starts the pressure down from the lower pressure setting again. And then whatever ramp time you set, it'll take that gradual time to find its way up again. But I wouldn't immediately change the pressure settings just because the patient complains of high pressure, because you want to find out, are they having difficulty falling back asleep? Because they just may have woken up and it may not have been the pressure. It's just that they woke up in deeper sleep, from deeper sleep, and the pressure requirements were higher there. You may start a lower starting pressure, but like I said, most of the time I will start the patient off at 4 or 5. So really nowhere else to go. And the machines will learn your needs as time progresses. So if you need something, let's say you started off at 4 or 5, the machine will learn you over a few days. And if it finds that you're spending most of your time at 8 to 9, it may actually then start you off immediately at 8 when you switch on the machine. Patients can have the choice at that point of hitting the ramp button just to start if they find that pressure a little overwhelming. But the machine's trying to learn you, but you have full control over the machine. You may add something called pressure relief. Now, what this does is sometimes when your air is being pushed in with the CPAP or auto CPAP at, let's say, 1 centimeter of 8 of water, it's hard to exhale sometimes against that 8. So there's these features nowadays which actually drop the pressure just as you're going to the exhalation phase. So when you blow out, it allows the pressure to drop. So you're not facing a wall of air that's 8 centimeters of water, 10 centimeters of water, even 13 centimeters of water. It will drop it. Now it can be set as an EPR or A-flex of 1, 2, or 3. What these numbers mean is that if it's 3, it will drop it from 11 to 8. If it's 8, it will drop it to 5. The concern I have is that a lot of DME companies are putting this up at maximum 3. What this allows is that when the pressure drops in exhalation, when you inhale, your obstruction occurs. And at that point, you end up having an apneic episode that wakes you up. So just because you have an EPR, I would be very cautious in using it. I either switch it off for most of my patients, or I set it at a pressure or a flex or an EPR of 1, just to give them some relief. Now, they come back complaining of, oh my God, I can't breathe out against it. It's such a problem. I will go ahead and increase that. But I find in most patients, if you start them off at 0 or 1, you should do fine because these machines titrate up and down the pressure based on need. Because of the concern that if you try to give them too much of a comfort level in terms of breathing out, they may develop an apneic episode. They're like, well, I wake up a lot at night. I'm not sure why. These patients look at the EPR, especially, or the A-flex. And its EPR stands for exhalation pressure release. So you want to make sure that you look at that as a potential setting issue that needs to be changed. Now, if they're intolerant to PAP pressure and you've changed the EPR or the A-flex, you've gotten them to sleep on their sides, for example, you may want to change from auto PAP to BIPAP. So send them in for a CPAP titration, especially in a lot of patients that are getting home sleep tests now. You will need to send them for CPAP titration. Find out if the pressure settings need to be changed, whether they need to maybe be placed on BiPAP. Now, I mentioned before as well with the dental appliance, but you can add this to anything else as well. Your CPAP can be adjusted or added to any of these therapies to allow for a slightly lower pressure, especially if high pressures are not tolerated. Inadequate pressure, I mentioned before as well, when we switch on or opt or maximize the EPR or the A-flex, patients tend to have an apneic episode. So I have patients immediately that tell me, oh, when I wake up, I feel smothered in the middle of the night. That doesn't necessarily mean that the pressure is overwhelming. I try to dive in a little bit and dig a little bit more below just, oh, I feel smothered. Oh, the pressure must be too high. Let me lower that. Actually, that's the wrong thing you should do. The right thing is to find out when they say, are you waking up feeling like you're choking? Yes. Or you're feeling smothered? Yes. Or you're feeling like the pressure is not enough. At that point, you might want to switch off the EPR feature. Or you also want to check to see whether you set the pressure range too narrow. And sometimes if they have a few more drinks than usual, alcoholic beverages, or they've changed medications and someone put them on opioids, you may increase your requirements. So you may want to then widen that spectrum of pressure range. Lots of masks, so that's no longer a problem. I think if patients know this, it's great, but you want to make them as comfortable as possible in the nasal mask. So I normally will not offer this as a, hey, don't worry about it. You can change it multiple times you want. Because as soon as they have the first couple of nights, they're like, oh, this is not working out. Let me switch my mask. What happens is they may switch to a full face mask, which actually then causes more problems down the road. So I normally, the DME company or even we will not tell them that you can change. But if we continue to have issues like patients complain I'm not working out, we'll go ahead and switch that out. And it's true, most manufacturers will allow a 30-day, no questions asked return on these masks to be exchanged out of something else. Now, if the patient has skin irritation, there's a lot of these new, Etsy has got this great website that has, you can look for CPAP liners. So what they do is wherever the mask makes contact, sometimes the rubber or so on causes irritation. You can apply these liners on your face and then apply the mask on that. So that's a pretty cool trick to use. You can make that on your own. You can buy that on Etsy. You have the more commercial versions as well. So look that up. Mask fitting can be done, but I say a lot of the times the leaks occur later on down as the masks get older. Masks get changed out every 3 months or so. So and they give you the liners, meaning that the patient has not only the hardware, the hard plastic part of it, but the soft part of it, the rubber. They have 2 or 3 not copies, but they have 2 or 3 versions of that, which they can replace then as they start getting more of a mask leak. Or you may want to try a different mask. Nasal dryness is also another common complaint as well. So you want to try, if you can ask them, patients have full control of humidity. I'll ask them to increase the humidifier level. Now the humidifier level is really dependent on the ambient temperature as well. So just because one level worked during the summer months, it may not work the same way in winter months as well. Patients who have optimized that, you want to ask them, is the level of water in the humidifier tank actually going down? So they refill that with the distilled water. But if they're not pouring more water in every other night or every night, that tells me that the humidifier itself may not be working. And they're complaining of dry mouth and so on. You may want to consider looking at that or having them send the device back or asking the DME company if there's a problem with that. Nasal passage dryness, nasal saline sprays work well. If they're complaining of congestion and so on, then you may want to try nasal steroid sprays. A heated tubing, most of the devices will come with a standard tubing, which is not heated, but some patients who live in parts of the country where the ambient temperature may fluctuate tremendously, they may find water logging in the mask itself, in the hose itself. And so in those cases, you may want to actually get those patients a heated tubing that maintains the humidification from the machine right up to the mask interface itself. Sometimes the mouth dryness could be they're getting a nasal mask, and the air pressure is actually causing them to open up their mouth slightly, and the air shoots out. So there's air traveling here as opposed to air traveling here to keep the airway open. That causes a lot of mouth dryness. So you may want to, if that's an issue, a persistent issue, you can still use a chin strap that actually just like a little bow tie that you tie around, and you can be bought from any website and so on, or you can switch to a full face mask in these patients. Patients who have claustrophobia, anxiety, and so on, I will get patients, I say, don't even switch on the machine, put on the mask first, read your book, watch your TV with the mask on. Just get the idea of having something on your face that's not going to cause them anxiety or claustrophobia. Again, the type of mask, you don't want a big hunking full face mask because that causes some claustrophobia. There are full face masks as well, like hybrid masks that sit right there. So it uses the nasal passages by having outlets here, and it also covers the mouth. So you may want to try a different full face mask, or you can try a nasal mask, which is a lot more petite and less likely to cause them claustrophobia. Have them use it before they switch on the machine. But if they attach the hose to the machine, a lot of these machines now will come with this auto start. So you put it on as soon as you take a breath, the machine kicks in. So you don't even need to switch it on. So I tell patients to disconnect it and just leave the mask on first, get used to it. If they're on anti-anxiety medications, continue using that. If they're on hypnotics, I may need to prescribe that as well. PAP naps is a cool thing. If I have patients struggling, we will send them to sleep labs. And this can be done during the daytime where they have an appointment set at the sleep lab. The sleep lab technician will work with them to see, make sure that they bring the machine in from home and also their mask. They will try them on different masks with their own home machine, have them sleep in different positions, see how it works with the leak, comfort level, and so on. Now check with your sleep lab if they do a PAP nap. And if they do, then you can go ahead and order that. All right, so we've spoken about appropriate follow-up care in these patients, how to troubleshoot, and we mainly focus on the troubleshooting of PAP or CPAP or auto CPAP because the fact that it's way more prevalent and it's going to be the go-to first-line therapy. All right, so we've kind of come to an end of this talk. So we just kind of, as a circle back, we talked about the different treatment options available, the upsides, the downsides to it. You're generally going to go towards PAP. You're going to try to optimize PAP the best way you can. So either you work with a good DME company or you have a good sleep doctor around. Feel free to reach out to us if you have any questions. And you want to make sure that the patient is truly has exhausted all options before you try all the other potential therapies. Because, for example, the mandible advancement device will only be paid for by most insurances if they failed attempt at CPAP. And you don't want to switch out to a MAD or an OAT oral appliance immediately, because again, we know that it's not as good as CPAP in terms of getting your AHI down, but it is good. And so you want to consider that, but once you've failed CPAP and you truly failed CPAP. Surgical options, we spoke about how it's unlikely to be the curative cause. I think it works really well in adjunct with CPAP, because if you have certain areas that causes the CPAP pressure to be high, I think it's reasonable. In patients who are very severe, then you want to do the MMA on the where they reconstruct the jaw itself, or you want to consider tracheostomy in the very severe patients. Mainly that will be hospital-based medicine. Then you also have other options such as weight loss, which I described, which is going to be something that you think about moderate, medium to long term, as opposed to a short-term measure. Now, if someone just has snoring and no other major comorbidities, I think that's reasonable. Or even a short course of, hey, let's see how you do. We're going to talk about weight loss. We're going to do all of these things between now and then we're going to reassess within 3 months what your symptoms are like. And then obviously talk about the fact that they may need to switch to CPAP if things don't work out. We then switched gears to talk about how to follow up someone on CPAP, meaning that how to look at the PAP therapy report, when not to be fooled by the PAP therapy report, especially someone symptomatic, knowing that a lot of patients now are getting sleep apnea tests, which is the home sleep test, because that's what it really truly is, which is only ruling out sleep apnea. If a patient continues to have symptoms, you have to send them to a sleep lab because that will allow you to figure out if they need higher pressures, they have a secondary sleep issue, or they may need to have BIPAP and so on. So those are the reasons why you would want to kind of make sure that if they are remaining symptomatic, so you want to look at the PAP therapy report, you want to optimize their symptoms, you want to educate the patient on what to expect short term, which is better sleep. Once they get a good amount of time, 4 or 5 hours of sleep, they should start feeling the benefit of the sleepiness, waking up unrefreshed, headaches, and so on. They should start feeling that. So those are the things to kind of alert them to. Nocturia should improve. So you want to check in. So that's why it's always good to document some of these things beforehand, before the sleep study or the CPAP, because then when they start using CPAP, you want to start focusing on those. Because if you just ask general questions and they're like, well, that was never a problem. That was not a problem. Don't have that issue. They start losing trust that in actual fact CPAP is doing anything for them. So when you actually dive in and say, is this actually improving? Is this, oh yeah, okay. Yeah, I used to wake up 3 times to use the restroom. Now I just wake up once, which is great. It doesn't fragment my sleep. I used to wake up with headaches more often. Now, even in patients who have a actual diagnosis of migraines and so on, you will find that you want to bring in that association with their comorbidities. Are the headaches as severe? Are you still feeling the same way? Is it happening as often? Are your blood pressure medications requirements going up? Do you always find your blood pressure high? So that's the medium to long-term goals, is just saying, okay, listen, now that you've been on it, now how does it seem to impact you? Because I think what you want to make sure the patient is a willing and educated customer or consumer, because that will drive their usage of CPAP. And that's what you really want to do. So always tie it in with their comorbidities, tie it in with their medications. A lot of patients find CPAP as, oh my God, I don't need another diagnosis. I've already got this and that and this and that. The last thing I need is another diagnosis, doc. Please leave me alone. I always explain to them that this may be the underlying issue, because once you have obesity as your base of your pyramid of ill health, if you want to call it that, then once you add sleep apnea on top of that, that perpetuates all these other inflammatory conditions like heart disease and whether you have blood pressure control or diabetes and so on. So you want to make sure that you treat that well and you help them understand why the sleep apnea is not only for sleepiness or not only sleeping through the night better, but it does have an impact, because some patients will be like, I was only sent here because my spouse hated the fact that I was snoring. So you want to always tie that in. Anyways, I think we've covered most of it right now, and I'm going to pause here. I want to thank the American Academy of Sleep Medicine. They have great resources. There's some free resources that you can look at as well, clinical practice guidelines and so on, and patient materials. So please look them up. I think they're doing a great job. Yeah, I'm going to pause right here and let y'all know that we're going to have our next webinar a month from now. It's going to be the final 5th series of our webinars of 5 webinars. We did Sleep 101. We did then, what did we do? Insomnia next. Then we did third installation was OSA assessment, evaluation and testing, where we talked about atypical patients, typical patients, how to figure them out, and then how to then test them appropriately. The 4th installation is the one today, which is OSA treatment and management, how to monitor them, how to make sure they're getting the best care they need. And the 5th one is going to be on circadian rhythm disorders and restless leg syndrome. All right, so I'm going to pause, and if you want to register, we will send out an email within the week as well for you all to register for that, or feel free to share that with your colleagues. But I'm going to open up the floor to questions that y'all may have. If anyone has questions, please feel free to chime in. Don't forget to unmute yourself as well. All right, while I wait for someone to have the courage to ask a question, we will also talk about, so what I want to show you all is my website as well has a lot of resources. So just please go ahead and under, what I will do is, oh, let me see how to escape this. Oops. Yeah, there we go. All right, so in the website as well, you can either register here for the next event. So the next event information should be there. But the resources tab over here has teaching videos. It also has our webinars attached to that. So you can look at, for example, this teaching videos, go on to the Respironics device. We much prefer the Respironics device because I think the algorithm is superior to all the other manufacturers out there. Patients are able to see how to set the device, how to troubleshoot issues, how to keep it clean. So you can refer patients here. We generally will get patients to have a look at this video before the sleep study sent out as well, just so that they know what to expect, especially the elderly. in nurse practitioners and doctors out there, we also have a whole lot of resources here. I apologize for my ugly handwriting. That's the best I can do. And well, no, that's not the best I can do, but you know. And so there are different options in terms of when you're dealing with issues and compliance or not loving CPAP and what's going on, when to repeat a sleep study, desensitization of CPAP. So there's a lot more deep dive. We also have respiratory resources here and weight loss resources as well. So you can go through that. We also have where the webinars are as well. It'll be important for you to look at. We actually have a whole lot of webinars. Our webinars are all attached here. And so you can click on these links and watch Sleep Med 101, the insomnia, and also the one on evaluation testing. The one from today will be uploaded as well within the week, so you can view that or have your colleagues view that. And the blogs also, I'm a big fan of the blogs if you like reading. And so we do everything from restless legs to restless sleep disorder in children, pulmonary issues, aesthetics and sleep disorder breathing or sleep apnea, how to quit smoking. And so we have multiple blogs that we try to educate the patient on, so at least keep them able to do these, to at least be able to have access to these education materials. The other thing is that I want to alert, if your patients want to just undergo a free sleep test, we work with the first FDA approved sleep apnea test that they can actually click on, register, and undergo a sleep apnea test on their Android or their cell phones itself. So whichever works for them, I would encourage them to do that, especially some patients who are not convinced that they have sleep apnea. This is a great tool for them to screen, and I'll be happy to get in touch with them once the results come back. I think it's good that we're democratizing access to sleep apnea testing, because the estimated number of patients, I think that they're estimating between 25 to 30 million people are still undiagnosed with sleep apnea. So I think we'll see that because of obesity is also increasing, we'll find those levels as well increasing. All right, I am going to pause right there and see. I don't think there's any questions. I think everyone seems to have had their questions answered. So we'll go ahead and stop right here. I appreciate everyone for listening in. We're always looking for feedback. So if you have anything to share with us, you can either email us. Please look out for the post-webinar test that should come out to you within the next 24 hours. We leave the window open to do the test for a whole week before we collate the information. And we will get the certificates out to you within a week of that. So 2 weeks from now. Thank you again. Breathe well and sleep soundly.